Hi, everybody. Thank you so much for joining us for this really exciting session. I am truly honored to be moderating this session today, where we are going to be focusing on GI disparities in different GI malignancies. For those of you who don't know me, my name is Dr. Shikha Jain. I'm a GI medical oncologist at the University of Illinois Cancer Center, where I'm also the Associate Director of Communication Strategies and Digital Innovation. We're going to start off today with just some quick introductions so you know who all is speaking today, and then we'll jump right in. So Dr. Kathy Eng, why don't we start with you? Can you give us a brief introduction on who you are?
Sure. My name is Kathy Eng. I'm a medical oncologist here at Vanderbilt Ingram Cancer Center. I'm the GI program director and co-leader of the research program here, as well as the director for young adult cancers program. And oddly enough, very similar to you, director of strategic relations.
Wonderful. Thank you for joining us. And Dr. Jacqueline Gaddy?
Yes, I am a new GI medical oncologist at Yale. I just joined faculty last August, and I recently completed my fellowship at University of North Carolina, and I am establishing myself as a health services researcher, evaluating the social determinants of health and how they impact cancer care delivery.
Fantastic. Thank you so much for joining us. And I will mention that we all kind of know each other, so we may jump between calling each other doctor and also by first name. So I just want to make sure you both are okay with that.
Of course.
Yes. And I actually met Jacqueline in person a few days ago.
Yes, we were just together.
I am very jealous. Hopefully we can do a little reunion of that at ASCO this year.
I think we're on a committee together, so I think that will happen.
Excellent. Very exciting. So let's jump right in because we have about 30 minutes to talk, and this topic I think is incredibly important. So we're talking about GI oncology as it relates to disparities in cancer care. And Dr. Eng, I'd love to start with you. Can you give us a little bit of an idea of what we mean when we talk about disparities in GI oncology and what you see and what we are concerned about?
Thank you so much. So just for the audience, I largely treat colorectal cancer. I do oversee the GI program, but my colleagues have various research interests, and so we separate our subspecialties. So for me, as a colorectal cancer medical oncologist, obviously I tend to see a lot of patients, and a lot of them unfortunately tend to present with stage 4 disease because they have often presenting with later stage of disease due to their misdiagnosis or due to the fact that they've not undergone screening appropriately. And the reality is that because we're large academic institutions, we tend to see younger patients to begin with. But the reality is, if you take a real, just a general overview of the literature, the literature is largely based for research purposes in a largely Caucasian patient population. We've got great trials that have been conducted, but if you actually look at the patient demographics, minority patient populations are truly a minority patient population. And I think it's very important to also, when you read the literature as a medical oncologist or any physician for that matter, you have to take into account selection bias. And we have to take into account the fact that we're not necessarily able to reach out to some of our patients that may not have access. Patient access is an issue, as well as, patient outreach is really important. And I don't know if we're necessarily doing the best job for that. And I think that's just a good segue to open up the rest of the discussion.
Absolutely. And Dr. Gaddy, what do you think? Outside of clinical trials, what other disparities do we see in GI cancer care?
To add on to what Kathy was just speaking about, I think one of the biggest things to realize when we discuss racial ethnic disparities, especially within GI cancers, and even on the topic of colorectal cancer, while minoritized patients are often not participants of these trials, they are also still very much heavily impacted by colon cancer. There's a known racial ethnic disparity with Blacks having a higher incidence and mortality of colon cancer. And as Kathy alluded to, oftentimes, unfortunately, also presenting at more advanced stages. And as time has gone on, we now are seeing, of course, this younger age of diagnosis of colon cancer, and that same mortality, or I should at least say incidence, we still see that disparity, unfortunately, within our minoritized patients. they're still presenting at a younger age, advanced stage, et cetera. And unfortunately, I do think a lot of this is a result of lack of screening, also lack of dietary options. And that really is like the focus of my research program. When I think about the social determinants of health, that is the main reason that these SDOH factors should in fact be considered at time of diagnosis to understand what exactly makes up this patient, not just their actual labs or their vitals, but what has caused them to actually miss an appointment or to miss screening. Was it insurance, transportation, et cetera?
I think that's a really good point. And I think another big concern is a lot of these patients mistrust the healthcare system. They don't necessarily want to come see a doctor. Many of them aren't getting, as you mentioned, Jacqueline, many of them are not getting screening because they aren't seeing a primary care physician regularly, or they just don't trust the process. And, understandably so, there's years of systemic racism within many of our healthcare protocols that can lead to that as well. And we've seen that Black patients especially can actually present at a much younger age, as you alluded to. And so there's even some recommendations that specifically discuss those types of inequities that we see and how we can get those patients in at an even earlier point to get their colonoscopies, for example. So I'm curious if, along with, social determinants of health have become a very, very important part of how we determine patients' cancer care after they're diagnosed. But I think that I'd love to dive a little bit deeper into how do we capture those patients before they become a stage 3 or a stage 4? How do we really address that disparity that has widened our outcomes, along with all of the other things that impact these patients and their potential ability to get treatment?
I think you bring up excellent points. And the reality is we want to capture those patients earlier, right? I'd rather not have a cancer patient in my clinic. I'd rather have prevention really take the lead on this. I think part of the problem is, number one, I know for a fact, and I think that for many of us, our parents probably didn't have some opportunities to necessarily take a whole day off from work, right? You have to take time away. You have to, it's financial stress, right? So you have to take time off from work. You have to ask your employer for the time off. Then you have to prep. Then you have to find someone to drive you, find a way back, and more importantly, I think it's also, a lot of people think about the prep, and that also dissuades people, right? But the reality is we have Cologuard now. We have other means for testing, but people often, it's surprising. I have a lot of patients that said they still have never been appropriately screened, and here they are showing up in my clinic, and I can't figure out why. And I once again, I don't know if it's because they don't have a primary care physician. And in all fairness, I think a lot of people do not, because they're very comfortable with their gynecologist or their urologist or their cardiologist, and they don't necessarily have a primary care physician. But I also think that we also could share a lot more information with patients in regards to community outreach and to enhance prevention. I wish we could do a lot of it through telehealth. But unfortunately, as we all know, telehealth varies across the states. And so even though our catchment area for Vanderbilt, right, involves like Kentucky and Mississippi, Alabama, et cetera. But I am so limited by what I am able to do via telehealth because I'm not licensed in each of those states. And obviously, each license costs a ridiculous amount of money as a physician. All the paperwork's different for each state. So I just feel like we could do so much more if we had, if we were allowed to educate others and to also, there's just so many aspects that I can go on and on and on about. I also think there's also, at least I know for my mother, who unfortunately was diagnosed with rectal cancer, earlier stage, but still stage 3. The reality is, I think, for the Asian population, they just don't like talking about screening, and they don't like talking about cancer. Granted, she was an older Asian population, but they don't like discussing cancer. And so she, even though I do what I do, she refused. until she was diagnosed. But her doctor also ignored her symptoms for a year. Almost 2 years, actually, I found out later on. So I think a lot of we must educate people to listen to their bodies. And then if your symptoms do not improve, please, please, please go get a second opinion. I think that's another issue altogether as well.
I absolutely agree with you, and so sorry about your mom. I know that, especially when it's a family member and it's something that you do, it can be very different sitting on it from the patient or the caregiver side. So I'm so sorry to hear that. I do want to amplify a point that you made about telehealth, because during the pandemic, I think we saw this amazing opportunity where we could be providing telehealth to people across the country. And that was such an incredible way for us to connect with many patients who, as you said, couldn't take the time off, because many times to get that colonoscopy, you need a visit before you get the colonoscopy scheduled. So now that's 2 days off of work. And so allowing physicians to provide that care to patients via telehealth was huge for many of those patients who have transportation issues or work issues. And now they're rolling back the ability to do that. And I was told, just as you mentioned, that we can't do telehealth with patients outside of our state, which is ridiculous, because it's not like me being a doctor in Illinois is different than me being a doctor in Indiana treating cancer. And so I think that that's absolutely something we absolutely need to be loud about, because that is a huge impact to all of our patients, and especially to those who have other barriers that can prevent them from getting into the office. Jacqueline, do you have anything to add?
Yes, I wanted to add, one of the narratives that I am hoping that we transition from is that we are often, as medical providers, we say that a certain population is not trusting. And I think it really is on us to say that the system has not been trustworthy. And that is really on us as providers, as clinicians. It is not the responsibility of a particular group that has already been marginalized and minoritized to now develop trust. I think it is instead on us to say, what have we done historically? So we know Miss Henrietta Lacks, we know the Tuskegee syphilis study, and those are the highlights, right? Those are the ones that got more publicity for obvious reasons, but Dr. Nguyen and many others have established that those are just like the very bare minimum when we think about the historical data that has actually caused this mistrust. So because of that, I strive personally within my own patients, and then here within the Cancer Center, I serve as the community outreach engagement liaison. And that allows me to educate the other members of our Cancer Center, specifically within the GI space, to say, like, no, it's on us. And I think once we start showing that, okay, these are ways that we can actually establish trust with our patients, I am hopeful that these marginalized patients will actually begin to trust us, because we are in fact now trustworthy.
I absolutely agree with you 1,000,000,000%. If I could applaud and stand up, I would, because we do the same thing in our cancer center. And one thing we've found that has been pretty effective, which I'm curious if either of you have done something like this at your centers, is finding those community champions, because a lot of times finding the partners in the community and partnering with your patients, even. I've had patients who have come in with a absolutely understandable mistrust of the system and the way their family members in the past have been treated. I work at University of Illinois, which is a predominantly Black and Latin American population. So a lot of patients really don't trust the system. And one thing we've done is, one, as Jacqueline, you put so eloquently, is we talk to them about why and how can we help and what can we do to help you regain trust in a system that has failed you and your family in the past. And then when we regain that trust, we talk about, okay, would you be interested in being, a trusted messenger in your community? Would you be willing to talk about colon cancer screening at your church or at the grocery store or with your family? And so building that trust, I think, is an incredibly important part of what we do, and acknowledging the fact that there is a reason that patients come in and don't trust us. And one thing that drives me up the wall is when people talk about, oh, this patient's non-compliant. And I say, no, non-compliance is a word we do not use, because believe me, if a patient wants to they all want to get better. It's not that they're intentionally saying, oh, I'm going to get worse, I want to be sick. It's not non-compliance. It's what are the barriers that are preventing them from being able to carry out the plan that we are recommending for them. And as their physicians, I always tell my patients, I don't go home with you. So I don't know what your life is like. I don't know what your day-to-day is like. This is the plan I'm coming up with you. In an ideal world, this is what I'd like to be for you to do. But you tell me if this is feasible. What do we need to do to make this something that you can actually implement, and how can we modify it? And I think making it more of a partnership and making patients feel that they're a part of the plan and part of the decision making, especially in the cancer space where patients feel like they've lost control the second they hear the big C word. I think for at least the patients that I've treated and the ones who've gone out and been my champions in the community, they feel like they have some ownership of their disease and of their ability to dictate the treatment plan to some extent and how it works with their life and with their work schedule and their family schedule. And I think that's a really important component that we need to incorporate into the cancer care we're delivering to address many of these inequities that, I mean, they're still very pervasive and we're still seeing it in the data.
I think it's also really, I have to say, we're very fortunate here. We have a lovely woman named Claudia Barajas that helps us with our Latino patient population. But I'm always concerned because she's one person, right? So I don't know if she can, I would like to hire 10 of her, but I also would like to hire 10 of her in other individuals with different languages. Because we're seeing, in Nashville, we're having increased diverse patient population just because a large number of individuals are moving in. And definitely, I'm always concerned about language barriers for our patient population. And we're trying always to encourage, we try to encourage our own doctors through the community outreach program, like, hey, if you're interested, and it's great. Some of the doctors are very interested in serving as an advocate, as you state, to reach out to the communities. And I think that's extremely important. It's nice to see somebody that they feel comfortable, that looks like them, they feel that they can identify with them. And I think that makes a big difference in regards to hopefully getting the information across about the importance of screening, if appropriate, or if patients are having symptoms.
And I think it's also great that this has become a part of the national dialogue. I mean, the incredibly sad news about Chadwick Boseman, I think really it encouraged a lot of people to go get screening. It brought the conversation in a national spotlight. And it was a very high profile, Black American man who was unfortunately diagnosed and, succumbed to the disease. And I think that having those big profile people talking about it as well also brings it into the national dialogue. So I think there's, we always talk about how patients get their messaging, and some patients get it on social media, some get it from the newspaper, some getting it from the TV news. So we have to figure out where our patients are getting their information and how we can get that information to them in a way that they will digest it and understand it and then trust it to come see their primary care doctor or see us or ask for a second opinion if they're having symptoms. So I want to talk a little bit about clinical trials because Dr. Eng, you talked about it a little bit earlier, but I want to delve a little bit deeper. One thing at our cancer center, we have such an incredible population of patients who have learned to trust the system and who are these amazing trusted messengers for us. And so we're able to enroll patients in trials who often are not your typical patients that we've seen in the trials in the past. The majority of the demographics have been Caucasian, and that we know is detrimental to this patient population. So let's talk a little bit about clinical trials, clinical trial designs, and why this challenge exists and how we can address it. So Dr. Gaddy, let's start with you this time.
Absolutely. I am actually in the process actively of submitting a career development award evaluating just that. And I think a lot of historical data has demonstrated that specific criteria has often actually just allowed certain minoritized patients to not even be eligible. That's one issue. We can think about things such as comorbidities. ANC is another one that's been widely evaluated. But then besides just how a trial is written, it can be written beautifully. But one of the biggest issues that has been established is that patients are just not being asked. Of course, this narrative is, okay, patients do not trust us and they don't want to accept, et cetera, et cetera. A lot of that is just rooted in implicit bias. Some of it is explicit bias. Some of it is just straight racism, which I'm going to call it if in fact that is what it is. But if in fact patients are not asked if they want to enroll in a clinical trial, they have no opportunity. And studies have been shown that actually demonstrate when patients are asked and they are educated in a way that they are then empowered to make an appropriate decision, they are often more than willing. And for me to be a junior faculty member, and I should specifically say, you know, I started seeing patients in October, and it is easy for me to get my marginalized patients onto trials. Why? Because number one, I look like them. I have to admit that. But then because I talk like them. I am from Buffalo, New York. I am an inner city child that was raised in the same environments that these marginalized patients were raised in. But set that aside, more importantly, I speak to them in a way that they understand me, that they hear me, that they see me. And because I automatically walk into the room kind of like stepping over that barrier, they trust me rather quickly. So the questions that I will often get is, well, Dr. Gaddy, would you do it? Or would you have your mother do it, et cetera? And I am only going to encourage participation in the trial that I would do if I, in fact, were in their same clinical scenario or if my mother was. But because of those barriers, again, that I am willing to understand exist and then hop over, jump over, dive through, or whatever is needed, I think those are the things that if in fact we strive to practice like that as all oncology providers, I do think that we would definitely see enhanced accrual amongst marginalized patients.
So I just want to say two things before Dr. Ng jumps in, because I think you made two really, really important points. So one, and this is a topic we could talk about for hours because this is another passion of mine, which is having patients and physicians who relate to each other, having physicians who look like the patient populations that they're treating, and having leadership that looks like the patient populations that we're treating. There is data and data and data that shows when you have diversity in leadership, when you have diversity in the physicians who are treating patients, that the outcomes are better for these, specifically for these populations of patients who can relate to the physicians who are treating them. So I want to emphasize that because we really need to be focusing on our pipeline of physician leaders and physicians and making sure that the representation in our leadership and in our physicians who are treating patients is representative of the communities that we treat. So I want to emphasize that point. And then the second point is you were talking about communicating. And I think as physicians, we often get stuck in our own heads, especially with oncologists who have really big words to describe really complex medical diseases, who have very long cancer chemotherapy agents that we can describe, and it gets very overwhelming for patients. So I want to emphasize that point you made of getting to where the patient's level is and explaining it to them the way you would explain to a family member or a friend. And that I think applies to everyone. When I talk to my patients, I talk to them the way I would talk to somebody who's not in medicine at all. You talk to somebody about it in a way that you want them to understand so that they can make an informed decision. And if you're throwing around a bunch of big words that no one understands except for you, you may look really smart, but you're not going to allow your patient to make an informed decision. So I just wanted to emphasize both of those two things. All right, Dr. Ng, sorry to cut you off.
It's okay. I could talk about this forever because obviously in all full disclosure, because I'm the co-chair of the NCI GI steering committee. So the reality is that in the United States, we fail to enroll enough patients to clinical trials. It's less than 10% of our patient population. And because that is a challenge in and of itself. The second aspect is that I fully agree. I'm successful as well in regards to enrolling patients when I have a trial, but I don't know if other people take as much time to do that, right? And in the community, they're so pressed for time. So I don't know what, I'm sure there are other barriers as well. But also we're challenged when there's a language barrier, right? So you're only allowed one or two patients to go on a study, but after that you have to translate the entire consent to another language, and then you're charged for it, right? So it's an incredible amount of money to translate the consent. And if you're running an NCI trial, which is always underfunded relative to pharmaceutical sponsored studies, then you're going to run into more barriers, which I find extremely frustrating, right? The other issue is I think there's so many other opportunities, going back to telemedicine, to help enhanced community outreach about what is a clinical trial. How can this clinical trial benefit you? Everyone is worried about a placebo, but the majority of trials do not have a placebo. And if they do, it's because there is no other standard of care. And that is why there's a placebo. But there's so many opportunities to help our patients that are already stressed financially, already stressed in general in regards to their new diagnosis, but to really reach out to the patients that do not necessarily live next to an academic institution or live in a large city where they have access to a large community provider, where you could theoretically pre-screen the patient. You could provide them information about the schedule. So what if they don't qualify? Because you don't want them to take off a whole day from work. And if they don't have the transportation, I mean, I have patients that drive hours just to come see me, right? From all across the state and other states. But they have had the capabilities to do so. And we all know there are those patients that do not have those capabilities. And I think that is part of the problem in regards to clinical trial enrollment. And then also we have to encourage clinical trial enrollment because we are now seeing there's so many small subsets for every single GI cancer, right? So you're hitting less than 5% for some molecular marker, and you have to pre-screen a gazillion patients to find that 2% of patient that has HER2 positivity for colorectal, for instance. So we have to do whatever we can to encourage clinical trial enrollment, but we have to make it easier for the patient. And if the control arm, if the patient's on a control arm, why can't he get that care with his community provider, who is a board certified physician? And can we not do a telehealth with that patient once a month? And he would get his standard, chemotherapy regimen at home. Then that way he won't want to drop out of the trial just because he's been on the control arm. So sorry, so many opportunities for discussion, but I just think there's so many opportunities to reach out.
Yeah, please do not apologize, because those were all fantastic points. And at the biggest point, I think one of the biggest points I want to emphasize is the telehealth component, but then also the fact that it takes time to enroll people in trials. And when you have 10, 15 minutes to see a patient, and then you're RVU based, and so your compensation is directly linked to how many patients you see, and you have administrators telling you that you need to see X number of patients a day, or you won't meet your productivity goals. I mean, this is not how we practice medicine. This is how we have a line of patients just coming in and out. What is it? A factory line. I mean, this is not medicine, this is business. And that is not how we should be taking care of our patients. We should be being able to spend that time and talk to them, and utilizing telehealth and allowing them to see their primary oncologist if they're on standard of care. So we have about 4 minutes left. So in those last couple of minutes, I would love to hear from each of you, maybe your final take home points. What do we need to do? You're going to fix this entire problem in the next 4 minutes. So Dr. Gaddy, why don't we start with you? What are your high points for solutions for how we can address these types of challenges?
So when I think about my mentor and I, we have this joke about how am I going to get my corner office? And my corner office is going to come by what we have discussed here, right? Like, we are not going to change this overnight. We're not going to change this in the next 2 minutes. But I think one of the biggest things that is a targetable solution is to work on communication, to work on community engagement. If in fact we are trying to evaluate the community needs to participate in that. So community advisory boards, they are attached to almost every cancer center. These are people that should actually be included at the start of the study. So that way we can actually have people that have their boots on the ground to say, yes, that is something that I think members within my community would appreciate, or in fact, they would not be a participant of that. So I think that's the biggest thing I really stand on, is let's start really fully evaluating the social determinants of health.
Thank you so much. I totally agree with you. And Dr. Ang, you've got the final word. So 2 minutes. Tell us what you think.
Well, number one, I want people to recognize their symptoms early on. If their symptoms don't resolve, they need to get a second opinion. And don't wait, and don't presume that their one doctor they saw knows the answer to everything. Number two, I fully agree with community engagement and outreach. I'm new to this role also as Director of Strategic Relations. I would love to see more engagement at community churches, at the community centers, and really reaching out to the community at their level. I would love to see more of that. But not only that, really capturing the metrics. Did they learn from what was provided to them? Follow up with them in 6 months or a year. Did they actually go get that screening completed, or whatever symptoms were being addressed, or whatever family member needed to be referred to a genetics counselor? Did they have something that they did following that lecture or discussion? Because there was a reason they showed up right at that community center that day. So I would love to see more engagement directly.
Wonderful. Well, thank you both so much for this incredibly informative and important discussion. I think the future looks bright in this space in the future with the two of you leading on these initiatives. And I hope we can have a follow-up in a year and see where we have come in the last year. So thank you so much again for your insight, for your hard work in this space, and for everything that you do. And to everybody who's listening today, thank you so much for joining us, and see if you can implement some of these strategies within your own cancer centers or within your own clinics. Thanks, everyone.
Thank you.